Welcome to the fourth in our series of school webinars on the role of different AHP professions. This webinar will take you through the role of the occupational therapist. We have 4 OTs talking about their careers and roles, and within that there will be some talk about the profession and entry requirements to get in. I'd be grateful if you keep your cameras off and your microphones off during the webinar, and there'll be opportunities towards the end to ask questions, but if you have any as you go along, please do ask them in the chats. So if you've been before, the AHP professions are the 3rd largest clinical workforce in health and care, and in the main they're degree level professions and are professionally autonomous practitioners. There are 14 registrable titles for the AHPs covering 16 roles, and you'll notice on this slide that there are 16 professions, and that's because prosthetists and orthotists are dual registered as one profession, and the radiographers, therapeutic radiographers and diagnostic radiographers are counted as one. There may be some professions that you've never heard of, and if you are interested in a career in health and care and you don't know what yet, I'd encourage you to have a look at the AHP roles. AHPs provide system-wide access to system-wide care to assess, treat, diagnose and discharge patients across social care, housing, education and the independent and voluntary sectors. Through adopting a holistic approach to healthcare, AHPs can help manage patients throughout the life course from birth to death, and their focus is on prevention and improvement of health and well-being to maximise the potential for individuals to live full and active lives within their family circles, social networks, education, training and the workplace. This is part of the 7 webinar series, and today's focus on OT, which definitely fulfills the full and active lives bit. I work really closely with OTs, and I think they're an amazing profession, probably should have been one in another life, and I really hope that you enjoy this webinar. And with that, I'm going to hand over to Sophie, who's going to give you an overview of the profession. Sophie is the professional lead occupational therapist in Ipswich, and an amputee specialist OT as well.
Thanks, Nick. So hi everyone, I'm Sophie, and I'm here today with my OT colleagues to tell you a bit about occupational therapy and why it's an excellent profession for you to consider in your future career. So what is occupational therapy? Will the slides go through on their own, Nick, or do I need to do it? Oh, lovely, thank you. So occupational therapy plays a vital role in health, social care and society. It enables people to have fulfilling lives at home, at work, at school and everywhere else through meaningful occupations. It enables people to manage their health and care needs and to do the occupation that they want, need and like to do. So us as occupational therapists, or as OTs as we're often called, we consider all aspects of an individual and their environments and work with them to create a plan to reach their goals. So I'm just going to play a short video now that will explain a little bit further by what we mean when we say the term occupations.
Occupations are the building blocks of life. But what are they? An occupation is any activity that we need, want, or like to do to live and to look after our physical and mental health. Occupations give us purpose. They shape who we are. They help us connect with others. Occupations are essential to living.
So as that little video just sort of described, our occupations shape who we are and build our self-identity. So when we're asked about ourselves, we might describe ourselves based on our work, such as I'm a teacher, I'm an accountant, or I'm an occupational therapist. We might describe ourselves based on our hobbies or what we enjoy doing, such as might describe ourselves as being a footballer, a singer, a movie fan. We might also describe ourselves based on our roles and relationships, such as I'm a big sister, I'm a mum, I'm a friend. Or we also might describe ourselves based on what we love to do. So seeing friends, going out for dinner, riding my bike, or taking care of my hair or my makeup. So all of these different things I've just described are occupations or tasks that build our sense of self. And if any of these occupations become disrupted due to injury, illness, or other factors, the impact to our sense of identity and well-being can also be disrupted. So this is where occupational therapy or OT comes in. We work with people in a range of settings and a range of ages, so right from birth all the way through to old age, to help address challenges with occupational performance or our ability to engage in the daily tasks and activities that build up our day-to-day lives. So we work in a person-centered, goal-orientated way. Also, thank you. Next slide. We work with people in a person-centered, goal-orientated way where the individual identifies what is most important to them to work on. So this could be getting back to the need to do tasks, such as getting out of bed in the morning, washing themselves, preparing food, getting back to work, or the want to do tasks, such as playing sports, going to the cinema, or doing their makeup. The great thing about OT as a career is that depending on the area you work in and the client group you work with, the job looks completely different. So it's a really varied career. And during this webinar, a range of OTs who work in different settings are going to tell you about what the job looks like for them. Next slide, please. So the UK currently has approximately 6 occupational therapists per 10,000 people. And with the population expanding and people living longer with multiple health conditions, this demand is only expected to increase. So as a profession, we are in demand. If OTs can help people with health conditions to live well, to live their best lives as fully as possible, this will help decrease the likelihood of them becoming unwell and needing hospital treatment in the future. So ultimately, this saves money and reduces pressure on our health and care services. So a very positive outcome from being an OT. Next slide. So how do you become an OT? So the training to be an OT, as Nick's already mentioned, is degree-based and it's a science-based degree. And this can be done as a Bachelor of Science, so an undergraduate degree, or as a Master's, so a postgraduate degree. And it can take anywhere between 2 and 4 years to complete, depending on the type of course and type of degree that you decide to go down. There's also an apprenticeship route into becoming an OT, whereby you can train on the job by working as a rehab assistant and doing your studies alongside working. This route requires that you already have a job as a rehab assistant and then you apply for the apprenticeship programme to do alongside your work. Training on any of these routes includes a mixture of lectures and seminars at university and placements on the job, so you get to go and experience the role firsthand as part of your training. And then moving on to once you become qualified, you're then registered with the Health Professions Council. And it's also very advisable to become a member of the Royal College of Occupational Therapists, who provide you with a huge amount of professional support. All newly qualified OTs start off in an entry-level job, which is often known as a Band 5 job within the NHS. And when starting out, you receive a really good amount of support, training and development opportunities on the job. This includes stuff like regular supervision with your senior members of the team to help you with your learning and development. Some of these roles at this level are static, which means you're kind of employed in one area or speciality and you stay working in that area. But more often within health settings, the Band 5 posts or the entry-level jobs are rotational, meaning you move between different departments at semi-regular intervals. And this is to offer you a really wide range of variety and experiences and learning opportunities to help with your development. So once you become qualified, the learning doesn't stop, basically. You get to keep learning and building on your skills as you progress with your career. There's also a preceptorship programme, which Band 5s complete in their first year, and this provides really structured teaching and training opportunities, as well as shadowing experiences and reflective practice to, again, help you build on your skills and your expertise and experience once you're qualified. So I'll now pass you on to my OT colleagues from the different areas who can tell you more about the fantastic and varied roles of occupational therapy in different settings. And I'll be talking a little bit about amputee rehab and OT in a little while. Oh, and here's just a few resources there. In case you're interested and you want to learn a little bit more after this webinar, there's a few really great resources there where you can find out more about OT.
I think it's you next, Sophie, to talk about amputees.
It's me next, no problem at all. You'll be sick of the sound of my voice. Okay, so as Nick mentioned, I'm a specialist amputee and prosthetic occupational therapist, and I spent about 10 years of my career to date providing rehab for amputees. I can honestly say it's an incredible client group to work with. Supporting someone who's been through a life-changing event such as amputation and helping them to regain their independence and return to those meaningful occupations that are important to them is a real privilege. I thought the best way to tell you about what being an OT in this kind of setting is like is to try and give you a bit of a snapshot of a week in the life of an amputee rehab OT. So I'll kind of go through the sorts of things that keep us busy day to day. So Mondays might include completing a home visit with somebody who's lost their leg above the knee due to poor vascular supply or poor blood flow. He's maybe walking with a prosthesis, but some of the time he still needs to use a wheelchair. So we're going out with him to his home to help him build his confidence in being able to walk with his prosthesis there and use his wheelchair around the home. He might be feeling particularly nervous, so we might need to be supporting him with his sort of psychological well-being during this visit, as well as thinking about the physical aspects of him being able to move around his home and manage those day-to-day tasks or occupations that he might need to do. We would be looking at his mobility on the stairs and accessing his bathroom, thinking about how he'll manage his personal care, so washing and dressing, food prep, and getting in and out of the property so he can get out and about in society. Thinking about getting back to driving, accessing the shops, being able to get to the bank and the pharmacy, but also those leisure activities I mentioned before, socialising, going out with his friends. All those things are things that as OTs we'd be considering for our amputee population to think about how we can support them back to that once they're home. Based on that assessment, we'd be making recommendations about what he might need to do in his rehab to prepare for going home, thinking about any equipment we might want to provide to make sure that his home is as safe and accessible for him as possible. On a Tuesday, you might be running groups for your amputee. So maybe running a breakfast group where you get people to come to the rehabilitation kitchen and practice making food and drink, whether that's from a wheelchair, if they're in their early stages of rehab, or maybe with a prosthetic limb to practice using either a lower limb or an upper limb prosthesis to prepare meals and drinks. There's often misconception in patients that you're teaching them how to cook in these kinds of sessions, but actually what you're teaching them is just a different way of managing something they can already do to support their independence and get them back to doing that task. Plus the benefit is you might get your breakfast cooked for you, which is always a nice thing. We then might be completing initial assessments with our physio colleagues, working closely with those other AHP professionals that Nick mentioned earlier, with the prosthetists, with the physios, with psychology to support those patients on their journey. So assessing what their stump looks like, whether their upper limbs are still in good working order, their current transfer and mobility status, as well as finding out about their work and education roles, leisure activities, and what's important to them. These assessments are often quite lengthy, but it really helps you to understand that person on an in-depth level, build rapport with them, and really get to know who that patient is and what's important to them, which is really at the forefront of occupational therapy. You also across the week be attending meetings with your MDT colleagues, with the nurses, the doctors, to really discuss that patient's progress, feeding back all the fantastic work you're doing in your rehab sessions with them and how they're progressing so that you can come up with a good discharge plan to support that person home alongside your MDT colleagues. We also do a lot of what we call cognitive assessments. This is thinking about someone's ability to remember information, recall information, process it, and use it to fulfill their daily activities. And part of OT is to be able to assess their cognition and think about how that might be impacting on their ability to complete their daily occupations and how we can support with overcoming that challenge. So as you can see, being an OT with amputees is really, really varied. It's a fantastic area to work in and really uses all those OT skills, the physical assessment, the cognitive assessment, the psychological support, and it's really, really creative as well. You get to think really creatively around how you can support people back, and hopefully the slide shows you some of the really interesting things that you can do to help people back to things like swimming, surfing, using a computer, all the things that we all want to do on a day-to-day basis. So I can highly recommend it. It's a very fulfilling and extremely rewarding role, and if you want to know anything more, please don't hesitate to ask.
Sophie. The next bit is a video that we recorded from a previous webinar from our social care colleagues in Suffolk. So I will play that next. Please let me know if you can't hear it.
As an occupational therapist, which was amazing. So what do OTs do in local authorities or in social care? So we can work in adult and children's services, and in terms of Suffolk, we are split. We cover the whole of Suffolk, and we cover Ipswich and East around the Ipswich Hospital, and wider areas the West around West Suffolk Hospital and Bury St Edmunds, Waveney up in the north there around Lowestoft, Beccles area, and we have some services that are county-wide. And within that, we have OTs in lots of our different teams within that, who would all have slightly different roles to do. So lots of acronyms, I'm afraid. Our front door is the IWS, Independence Wellbeing Service. So they're doing a lot of quick, short-term, urgent stuff as people first come through. We have a neighbourhood teams, an integrated neighbourhood team. So that's locality-based, working alongside our health colleagues. Home First is our reablement service. We have OTs in there. We have an adaptations team, mainly looking at major adaptations and DFGs, and they're the independent Living Suffolk team. They're a county-wide service, and we have some OTs working in learning disability and autism. And I think the key thing for us is obviously we work with people where they're living, where they live their lives in the community. That could be at home. We could see people who are in prison. We could see people who are living in care homes, and we do have some input into people in schools with children's services. So lots of variety of where we work, and it is visits out to people in their own, where they're living. In terms of what we do, I think it's a really exciting place to work. We work with the community. We very much focus on people's well-being and enabling them to live the life that they want to live. Obviously, by what we do, by enabling people to being more independent, we have quite a influence on preventing, reducing and delaying the need of care, which is part of legislation that we work to in the Care Act. We have a very big influence in that. And I think we have the ability to adopt a very person-centered approach. We work in a strengths-based way, really being able to use your OT skills at looking at people from the person, the environment and the occupation that they're involved with, although mainly those occupations are related to the self-care and activities that happen at home. And I think social care often are thought of being the providers of equipment and adaptations, but we can get involved in doing other things. So we can look at compensatory strategies and techniques for people to do things in a different way. Obviously, environmental adaptations, of which can be minor or major adaptations to the person's property. Very much lots of equipment provision and lots of complex specialist equipment we get involved with. We look at digital solutions. We try to support people to learn new skills or do things in a different way, practice their existing skills. We often give information and advice and very much try to help people to help themselves where they can. That's very much the drive that we try to do, is support people within their communities to be able to thrive as they can within the support that they've got around them. So that's a real whistle-stop tour of occupational therapy in local authority. It's a great place to work, and if nothing more, I used to love driving around Suffolk to visit people in such different and often challenging situations and properties.
For Fiona there, it's a little bit funny seeing my video and Sophie's up on that screen at the same time. Anyway. And now I'm going to hand over to Vicky. Vicky is going to talk about her role in... Yeah, Vicky.
Thank you so much. So I'm a Principal Allied Health Professional at the Norfolk and Suffolk NHS Foundation Trust, which, depending on life experiences and contacts that people have had, you might be aware it's the Mental Health Trust that covers Norfolk and Suffolk. I've been really delighted by what I've heard in the previous two presentations, because it's really demonstrated to me that occupational therapists, despite working in these really varied settings, have got so much in common, and I could really relate to all of the different interventions that were described by Sophie and Fiona. But I want to explain to you guys how we tend to apply these in a mental health setting where someone has a mental health problem and may or may not also have physical health issues. I'll go on to the next slide, please. Thank you. So NSFT, it's a NHS trust. It serves 1.6 million people across Norfolk and Suffolk. So as you can imagine, that means that we've got occupational therapists working in a really broad range of different types of team, dealing with different sorts of mental health presentation, all the way from perinatal teams, mother and baby units, issues of attachment where children need support to build a relationship with their parents and the parents need support to build that relationship with the children, all the way up to adults who might experience a range of issues like, for example, psychosis or schizophrenia, or depression or anxiety, or issues with their personality. And then we go all the way through the lifespan and work with people with dementia too. So depending on where a career pathway in the mental health trust takes you, you might end up specialising in a different sort of setting. We also have inpatient services. So these are hospital beds for people who, for one reason or another, unfortunately aren't safe to be in their own homes at a given time. And although we work really hard to keep people out of hospital and make sure they can stay in their own homes, there is a big role with occupational therapy in helping those people that do end up in a mental health hospital to have the best quality of life and have the quickest return to their home environment. I'll go on to the next slide, please. Thank you. So in terms of occupational therapists, we've got 183 working at NSFT, and we also do have a range of the professionals that were described by Nick at the start of the presentation. I'll go on to the next slide. I really want to get to the case studies. I'm really keen to get through to those. And similar to what you've heard, particularly from Sophie, we all look at the same thing, which is to try to enable what we call occupational participation. And that means trying to help people to address the barriers that are stopping them from doing what's important to them, the things that they want to do, the things that they need to do, and the things they like to do as well, all very important. And through those interventions, in all sorts of areas of their life, from self-care to looking after themselves to the sort of sports or hobbies they want to do, we try to improve their quality of life. And obviously with a mental health problem, that does impact on people's quality of life. Yeah, next slide, please. NSFT, as I mentioned, have teams that work with all different sorts of client groups at different ages. And those people can be facing different challenges related to their life stage. I suppose given that we're talking to young people today, I should mention that we have quite a number of services that support people with mental health challenges and wellbeing challenges who are young. And so we've got a really wide range of really accessible options for care. Okay, I'll go to the next slide. It's funny not getting to move the slides. So this is what I really wanted to get onto, talking a bit more practically. Now, my background has been working in inpatient units as well as in teams for people with psychosis who live in the community. But I wanted to touch on 3 examples that we've brought forward from our clinicians to share with you guys. The first one is, obviously these are all anonymous, I should say. The first one is someone on a mother and baby unit, which we obviously have one of based at Helsden Hospital. And in this situation, the occupational therapist was able to help a new mother with postnatal depression to bond with their child, to think about looking after their child, the roles and routines that are involved with that, but also taking care of themselves through their mental health crisis. And I'm always really inspired by what happens on that unit because they're a very creative workforce. So they do a lot of arts type based interventions. They also do a lot around people's basic needs, so helping mothers to establish those relationships with their babies at a really, really critical time. And that person was able to go home and have a successful bond with their baby, and also a reduction in their depressive symptoms. So that was a really positive one. The one in the middle, this is one that we transcribed from one of our child and adolescent mental health teams. So this is a young man with depression who stopped going to school, didn't often go out of his room, and had lost interest in his hobbies and his friends. And in this case, it was a lot about the sort of transition from kind of childhood to adolescence. The young man unfortunately experiencing depression and not really being aware of what steps he could take to gradually move towards the sort of life goals that he had for himself. So the OT was able to work with him to re-engage with his hobbies and interests through music, which he was really interested in, and he ended up going to a community music group. And then gradually, through the process of helping him to build confidence and what we call self-efficacy, so his belief that he could achieve things in his life that he wanted to achieve, he was able to reconnect with school and friends as well. So yeah, and the third one as one a bit more from my own experience. So we often work with people who have a number of impacts from psychosis or schizophrenia, where they might lose interest or lose their motivation to do basic things like looking after themselves, looking after their flat, being able to engage with their family. And so in this case, a lot of work went into this case to help them to build a meaningful routine that made sense to them and that featured the sorts of activities that would motivate them to want to look after themselves, look after their environment. And we're also able to get Ahmed, in this case, obviously anonymised, involved with some activities that really helped to build his confidence, as well as do some work around finances, which was something that was causing a great deal of stress to this client. So yeah, just some case studies. They're quite varied. On to the next slide, please. And I just wanted to touch very quickly on this. So obviously you'll all be aware that mental health issues can be lifelong for some people. A lot of mental health issues can be very successfully treated with things like psychological help through the wellbeing service, or also in some cases medication can be really helpful. But longer term, we want everyone to be able to experience what we call a recovery, and this comes from the service user movement, where they experience a good quality of life, whether they still have symptoms or not. And I think that occupational therapy is one of the professions that is really critical in helping to look at how that quality of life and how that meaningful recovery can be achieved in mental health settings. I think I've got one more slide. So this is just about the career pathway, which we've touched on a little bit, and then I'll wrap up. So quite typically, we would have people come into our profession, into our career pathway as an occupational therapy assistant or a support worker. In that sort of setting, you're likely to be based in an inpatient unit, although sometimes in a community team, and you'd be doing a lot of that practical activity delivery, because activity is the treatment of occupational therapists. Other professions might use talking therapy or medication, but we use activity, and our OTAs, as we call them, are really pivotal in delivering a lot of those kind of activity groups and sessions. Then often through apprenticeship, people might move up to what we call a Band 5 occupational therapist or a junior OT. And in that sort of setting, they might specialise in a particular area, but often they would spend time in different areas learning about how to work with older people, adults, youths, any sort of area that they're interested in. And then as you progress, after around 2 years, usually, people would move up to specialise in a particular area, like, for example, community or learning disability, and develop their specialist skills. And I put the salaries on there as well, because I think, it's good to be transparent about what the salaries are, but those are the starting salaries. And in the NHS, we take a couple of steps up in our bands. So it's very transparent. You can look up how much you might earn in this situation on the NHS website. Yeah. Okay, I think that's me. I'm sorry if I went over the time.
Thank you, Vicky. I love how there's so much, like you all are talking about the same kind of things, just in a different context, and it's really great. Should have known about it before I decided to be a physio. I'm going to hand over to Jo, who's a paediatric occupational therapist. Jo.
Thank you. The downside of going last is it might be repetitive, but I think actually what it is hopefully reinforcing some of what you've heard already. So we're working with children and young people to do what you've heard already, to participate in the things that they want to and need to do, and things that are important to them, because some have difficulty because they have physical, developmental or learning delays, sensory or mental health needs, or there might be a period of time where they're suffering illness or injury. They may have challenging family circumstances, environmental challenges. or things that might be happening as they grow and develop. So there could be a number of issues sort of going on where we might want to get involved. Next slide, please. So who do we support? So we are working with babies, right from sort of premature babies all the way up to children up to 19 and young people up to 19. So physical, developmental, sensory difficulties. So particularly those with physical and neurological impairment. We do work with a number of children and young people who have cerebral palsy, which is something that's caused by damage to the brain before birth or infancy. So it's a lifelong condition. So we get to know those children and families really well over the time that we're with us. We have children and young people with neuromuscular conditions, so that's problems with your nerves and your muscles, impacting the communication between the two, so maybe causing sort of different sensations, pain, fatigue. So we're working with children with those conditions, those that have genetic conditions like Down syndrome, those that have injured themselves or in hospital or having operations, those undergoing cancer treatment that may have interrupted, their life, may have stopped them going to school, maybe causing some sort of unusual sort of fatigue or pain, or just sort of going through that treatment process. We work with preschool children with autism. We work with children with sensory processing differences, and then children that might just have more sort of minor motor coordination and functional difficulties that just as impacting parts of their lives. So how do we help them? Well, as you've heard, the occupations we're talking about are things that you probably don't think about every day, but your routine activities, your self-care activities. So we might be helping with sort of posture stability, muscle tone, strength, practicing skills, learning new skills, fastening buttons, getting dressed sort of a bit quicker. So anything around sort of self-care. Your productive occupations. So the main occupations when you're a young child is sort of learning and development, and then you're going to school. So things that might be helpful at school, being able to sit and do your handwriting, developing your fine motor skills, using scissors, and just being able to focus, engage with your learning and your lessons, organise yourself, sort of manage your school day. And then most importantly, play and leisure. So babies developing their play skills, learning how to coordinate their hands and eyes, using their hands and fingers to grasp and hold and operate and play with toys. Growing up, getting used to their gross motor skills, ball skills, being involved in PE and activities outside of school, socialising and taking part in sports or undertaking hobbies. So we're definitely about practicing skills, breaking down tasks to make things easier, maybe doing things a bit differently to help children achieve them. Maybe sometimes there's bits of equipment to help with that. But if there's issues in any of those places, it can really impact confidence, and it can then really impact maybe social skills or engaging in those activities. So how do we do that? So as others have said, we provide assessments, we give advice, and we provide therapy and interventions across a number of settings. So that might be sort of in and around hospital. We have clinics at our opposite sites. We work in nurseries, within mainstream schools like yours, within special schools, and with families and children in their homes. And we use a range of things. We use some very standardised ways to look at things, or we just might play with children and observe what they do. That's the really fun part of our job. We get to do a lot of play. We use toys and activities to see what their strengths are, what their challenges are, looking at how they're engaging in that task and how they might be able to perform it better. As others have said, we really want to kind of land on a goal with a family or a child or young person to work towards. We want to make sure that goal is achievable, and we want to have activities to help them work towards that are motivating and that they'll want to engage with. So we might do that therapy in home and in school, working with parents and with teachers to just keep that engagement high. And yeah, with that, if it's meaningful and they're engaged, then hopefully we'll get some nice results and they'll achieve their goals. Next slide. And so what do those interventions look like? Well, it's graded based on what we're trying to do, what the child's trying to do, what their difficulties are, what their strengths and challenges are. So at the lowest level, we've got lots of advice and information on our website. We have pre-recorded sensory and motor skills and coordination workshops for parents and schools to look at. But as I've said, for children with cerebral palsy, we're probably working with them throughout their lives from sort of once they're diagnosed up until 19. So we'll keep an eye on what's happening with their body, with their upper limbs, with their lower limbs, looking at how they're able to do things. That condition can affect in different ranges of severity in different body parts. We're doing sensory assessments and interventions. We're looking at how babies and children are feeding, how they're dressing, working on their own independent skills. In schools, we're looking at sort of pencil grasp, handwriting programs, how children are using scissors. And for those that are more physically disabled, just checking sort of their postural assessment, reviewing their environments at school, at home. Do they need specialist seating for play or for learning or for eating? For non-mobile children, we're looking at sort of wheelchairs, systems to help them sleep and position in bed, splints that they might need for their upper limbs or hands. If they're non-mobile, how are they being transferred around? Are they being hoisted? How can we help with that? And do we need different solutions for toileting and bathing? We also run groups. We also get involved in lots of specialised clinics with other healthcare professionals, speech therapists, physios, paediatricians. And whilst we're doing all of that, we're trying to provide really holistic support for families, signposting to other places that may be useful for them and making referrals. Next slide. So our service sits within West Suffolk NHS Trust, which serves Suffolk and around 280,000 people. Within West Suffolk, we sit within the Integrated Community Paediatric Service. So whilst there's lots of OTs in other areas of that trust, we're within a team that sits with other services, including hearing, audiology, nursing, psychology, the healthcare medical professionals, speech and language, physio. Our team within that, there's 28 of us and we cover the whole of Suffolk. I don't know what the ratio is to one person to how many children. I should have worked that out. So there's 28 OTs and 5 OT technicians, which is essentially a bit like a rehab assistant that you're sort of band 4 level. We've got a base in Bury St Edmunds covering the rest, Ipswich in the east, and we also do work in the Midlands Day Market. We also work within acute hospitals and tertiary centres, so liaising a lot with children that have had operations or sort of illnesses that may have totally changed sort of how they go about their daily activities. We also offer a lot of shadowing. So if people are interested in OT or in paediatric OT and want to come and spend the day with us, we always try and find time to do that. And obviously students that are on a degree programme or an apprentice programme, as part of that journey, they're required to do placements and spend time in professional settings. So we have a lot of students with us during the year, sort of learning about this particular area. I think the last slide talks a bit about that. So, you know, if you're interested in becoming an occupational therapist, and you're interested in community work, this role really helps us build really long-term relationships with children and family, which is what I love most about this. It's really varied. We see a lot of different conditions. We're working with a lot of different children and young people. So the student that's been with me the last 4 weeks is in her first year of a degree at the UEA. She talks here in this quote about how she didn't know much about occupational therapy. She started looking at courses. She thought it really met with some of her qualities. She then did a bit of research on YouTube and TikTok, and that's a great place to look at actually OTs doing things, to see what, how they do it and what they're doing. And she's come to us, she's interested in PEDS and she's enjoyed the variety, enjoyed working with lots of different children, looking at our different assessments and our interventions, and getting involved in running a group in a primary school. So hopefully that's given you a little bit of a snapshot. It is a profession you can come in straight from school or college, but I myself came in quite a lot later. So if you remember this webinar and it's not something you want to do or you do straight away, it might pop back up at some point later in life, and it's definitely a profession we welcome people in at any point.
Rookie error. If anyone's got any questions, type that in the chat, or you could ask it. Well, come on, you can unmute yourself. Oh, Vicky.
I was just thinking that I should have taken the opportunity to point out where people can get help if they are experiencing a mental health crisis. So if it's okay, I'll just put that in the chat. We've got a web page with a few different options, just in case anyone is thinking that they did need any support.
That's nice, and we'll put that in the YouTube channel. Thank you, Vicky. And then with that, we're going to end. So we've had 4 of our webinars already, and then we're going to start them up again in October. So you have all of September free. So the 1st of October, we're going to talk about diagnostic radiography, and then therapeutic radiography and speech and language therapists later in the year. Please do have a look at all of the information that's around those AHP careers if you're interested, and at the previous webinars that we've had as well. You've got me sold on OT. I think I'm sold already, but I just think it's an amazing profession, particularly if you really want to help people do the things that they love doing, and that feels like that's what it is. Thank you very much for joining, and take care. Bye bye.